Now, for the much awaited session of the day, we have got an interesting case presentation from ASTER Medcity. It will be presented by Sanjana Nair, PG Registrar, and it will be moderated by Dr. Geetha Phillips, Lead Senior Consultant, ASTER Medcity, and the Director of Academic Affairs. Over to you, Dr. Geetha Phillips.
Good evening, everybody. It's always an honor or a privilege to introduce a senior colleague. But it's a great happiness to introduce a junior doctor, a junior colleague. So my first function is to introduce Dr. Sanjana Nair. And Sanjana is an IMT training, second year IMT training, that is an internal medicine trainee at ASTER Medcity, and she's aspiring for the MRCP exams. Sanjana has done a very meticulous work in preparing this case and make it very interesting for you. So we have to encourage her. And then Sanjana also believes that all work and no play makes Jack a dull boy. She's an accomplished dancer, Bharatanatyam player, is that right? But now she says she's interested in cinematic dances, and she makes our life very interesting. So I think that also is an important facet of one's personality. Now Sanjana has many questions for us, so we will have to answer the questions. Her patient was toxic, and she wants to know why. So please, Sanjana.
Good evening, all. Thank you, ma'am, for the introduction, and thank you, API, for this opportunity. What if a benign self-limiting illness present itself as toxic, and why could it be toxic? Here is a case of a 52-year-old gentleman who presented to our hospital with a history of diffuse skin rashes over the trunk, which initiated over the trunk and later on spread over the face. And this was first noticed on 26th May 2022. It was associated with a 2-day history of low-grade intermittent fever, not associated with chills or rigor. He had associated headache, myalgia, and loss of appetite. 5 days following this event, he developed altered sensorium and breathing difficulty, for which he was brought to the emergency department 5 days following it, that is on the 1st June 2022. There was no recent history of any febrile exanthematous illness in the family. There were no other complaints of cough, sore throat, diarrhea, or vomiting in the patient. Looking into the past medical and surgical history, he was a known dyslipidemic on homeopathic medication for the past 3 years, and he also had a history of clipping done for hemorrhoids 2 days prior to the onset of rash, and this procedure was done from a non-medical center. And further details were not available. On arrival to the ED, this patient was conscious, but he was highly irritable. On ABCD examination was also done for this patient, and the airway showed oral secretions. He was having a labored breathing with a respiratory rate of almost 32 breaths per minute. He was tachycardic with a heart rate of 120 per minute, and he had hypotension. The blood pressures were accordingly 90/60 millimeters of mercury. Mercury, and he was febrile with a temperature of 100 degree Fahrenheit. He was not maintaining room air saturation. He had a saturation of 78% in room air. Systemic examination was also done, and the chest examination revealed equal air entry bilaterally, but there were reduced breath sounds and minimal crepitations on the bilateral lung fields. The cardiovascular and the abdominal examination were normal, and on CNS examination, he was disoriented in time, place, and person. Pupils were equally reacting to light at the time of arrival, and there were no focal neurological deficits. In view of his poor GCS, desaturation, and the labored breathing, he was sedated, intubated, and mechanically ventilated, and he was further evaluated and managed in the ICU. On local examination, he had papulovesicular skin rashes over his trunk, the scalp, the face, the genitals, the perianal area, the upper and the lower limbs, sparing the palms and the soles. Conjunctival hyperemia was also present in the patient. While intubating the patient, we also noticed that these vesicular lesions were extending from the oral cavity into the larynx, and the bleeding was also found from certain vesicular lesions in the skin and from the oral cavity. So this was a typical skin rash that was seen in the patient. As shown, the first two, the palms and soles were spared, and it was mainly seen over the trunk and the face, and it was also seen over the genital area. So at this juncture, what could be the possible differential diagnosis that could have come to your mind? Anyone who would like to contribute? Okay. Any other contributions? Any differential diagnosis? Sorry? Okay. So actually, similarly, from the clinical history and from the history and the clinical examination, the first diagnosis that came to our mind was a viral exanthematous illness, which was pointing more towards a herpes infection, which could be a varicella zoster virus or a herpes simplex virus. The other possible diagnosis included a toxic epidermal necrolysis. It could also be a pemphigus or a bullous impetigo, considering the generalized rashes that were seen in the patient. So these were the possible differential diagnoses that were considered. So to confirm the diagnosis, we had performed the routine blood investigations as usual, and labs showed neutrophilic leukocytosis with a total leukocyte count of 14.75, out of which 71% were neutrophils. He also had thrombocytopenia with a platelet count of 30,000 cells per millimeter cube. He had elevated inflammatory markers, that is a CRP of 74.39. The renal functions performed showed was also deranged with high creatinine values of 3.99. The liver function test was also deranged with significantly elevated liver enzymes. SGOT and SGPT was of the range of thousands. And the coagulation test was also abnormal because he had increased prothrombin time and an INR, and the INR was almost 2.13. Dyselectrolytemia was also present, and the potassium levels were 5.17. So serological analysis was also done, which comprised of the HIV, hepatitis B and hepatitis C, which were also found to be non-reactive. So this is to summarize on the labs, which showed neutrophilic leukocytosis, thrombocytopenia, deranged liver function test and renal function test, hyperkalemia, and features of coagulopathy. This was a chest X-ray that was taken at the ED, where bilateral infiltrates were seen, and ECG was showing features of sinus tachycardia with non-specific STT changes. Troponin levels were also done at that point of time, which was found to be 1855. A possibility of a viral exanthematous fever precipitating myocarditis was considered. So about the patient, how he was treated. He was immediately sedated, intubated and mechanically ventilated because he was continuously desaturating and he had a poor GCS. He had hypotension, for which he was started on inotropic supports, which included noradrenaline and vasopressin. He was given IV fluids and electrolyte correction. After sending cultures from blood and taking smears from the vesicular fluid, that is from the vesicular lesions, he was started on IV antibiotics, that is mainly IV meropenem was started on, and he was also started empirically on IV acyclovir. His arterial blood gas analysis showed severe metabolic acidosis, and he had deranged renal function with nil urine output. So he was initiated on CRRT as he was not tolerating hemodialysis because this BP was on the lower side. In view of all the abnormal lab parameters, he was given transfused with all blood products, which included the platelet concentrates, cryoprecipitate, fresh frozen plasma. Later on, he had continuous bleeding from the vesicular lesions, and his hemoglobin was also downtrending, for which packed red cells were also given for the patient. The blood cultures that were sent initially showed no growth after 48 hours of incubation. And the Zank smear that was also taken from this after scraping from the lesion showed the typical multinucleated giant cells and acantholytic cells, and that was suggestive of a viral cytopathic effect pointing towards a herpes infection. This is how we narrowed our diagnosis to. However, the IgG and IgM antibodies that were sent, VZV, that is a varicella zoster virus, IgG and IgM, were found to be negative. These were the typical Zank smear findings. The first onto the right shows the acantholytic cells that were evident in the Zank smear, and the second represented the multinucleated giant cells. That was the diagnostic feature for the varicella zoster virus infection. So now summing up on the history, the clinical findings and the laboratory investigations, we finally came to a diagnosis of varicella zoster infection with no secondary bacterial infection and a possible toxic shock syndrome and multi-organ dysfunction involving the brain, the lung, the kidney and the heart. It was a herpetic infection, but we ruled out herpes simplex virus because of the typical generalization of the rashes. Usually the herpes simplex virus is confined to the oral and the genital areas, but such generalized vesiculopapular lesions sparing the palms and soles are typically found in varicella zoster. So that is how we've narrowed our diagnosis to a varicella zoster virus infection. So getting back to the course of the patient, amelioration of the sensorium had occurred and patient was showing a brief period of improvement within the 12 to 24 hours of initiation of treatment. He was extubated as his GAC has improved and he was maintained on BiPAP supports. The inotropes were also de-escalated as the blood pressures were normalizing. But CRRT was stopped and hemodialysis was initiated as the patient continued to have a nil urine output and his renal functions were still deranged. During the hospital stay, he had continuous fever spikes, so a repeat blood culture and a repeat chest X-ray was also done. However, the blood cultures were still negative on repeating it. The antibiotics were escalated to teicoplanin. The IV acyclovir was stopped after 7 days. This was the X-ray that was taken because he had persistent fever spikes, which showed an increase in the infiltrates on bilateral lung fields. And in spite of the definitive and supportive measures, the patient had succumbed to his illness 1 week following the admission. Shortly about varicella zoster virus. Varicella zoster infection is caused by the varicella zoster virus, which is also called as a human herpes virus 3, which is the alpha herpes virus. It is a double-stranded DNA virus. It causes, one is a lytic infection that is called as a varicella zoster or the chicken pox, and the latent infection which can later on get reactivated to form the shingles or the herpes zoster. So the main targets of the varicella zoster includes the T lymphocytes, the epithelial cells and the ganglia. So this is shortly on the pathogenesis. That is the varicella zoster virus, as I already mentioned, the main target are the T lymphocytes. So the virus attaches to the cell membrane of the T lymphocytes. Next, it undergoes fusion and uncoating. And later on, the uncoated capsid is released into the cytoplasm. And this will bind to the nuclear membrane where it creates a nuclear pore. The DNA is released into the nuclear material and it undergoes DNA duplication to form the viral proteins, which includes the immediate early proteins, the early proteins and the late proteins. So in an immunocompetent individual, usually the innate immunity will delay the process of the DNA duplication so that the body gets enough time to produce the adaptive immunity. So later on, the virus is so powerful that it overcomes the innate immunity. It gets released into the bloodstream and produces the generalized vesicular rashes on the body. But the adaptive immunity would have developed by then in an immunocompetent individual, which later on suppresses the infection. That is why it is supposed to be a self-limiting benign illness. And later on, what happens is the virus from the epidermis enters into the epidermal nerve endings, and it undergoes a retrograde axonal transport, and it goes into the dorsal root ganglia. That is how it remains dormant for years, and whenever the patient is immunocompromised or if there's an acute stress in the patient, it will release the virion particles. So that is how later on the herpes zoster or the shingles will develop in the patient. So this is what I've mentioned now. And complications are rare in healthy individuals. If at all it occurs, it includes a bacterial sepsis, pneumonia, encephalitis, and other hemorrhagic complications. And herpes zoster itself can produce certain complications, which includes the post-herpetic neuralgia, meningoencephalitis, myelitis, cranial nerve palsies, vasculopathies, gastrointestinal ulcers. So these are the complications. Shortly, on the complications again, it causes herpes zoster, that is also called as shingles, which is commonly seen in 15 to 20% of the patients. It is mainly affecting the elderly and the immunocompromised individuals. Secondary bacterial infection and soft tissue infections are the next. Otitis media, pneumonitis, which was actually seen in our patient as well, osteomyelitis, septic arthritis, endocarditis. A toxic shock-like syndrome is another feature which I will be describing shortly. Thrombocytopenia, which is also seen in our patient, hemorrhagic varicella, encephalitis. So the two main causes of death in a varicella zoster patient is the hepatitis and the pneumonitis, which was unfortunately present in our patient, and that was the main cause of the death in the patient as well. When compared to the children, adults are at a higher risk of getting admitted for varicella, and they have almost 20-fold higher risk of developing complications such as pneumonia and encephalitis. So the risk factors that are identified in adults for varicella pneumonia is the underlying chronic lung disease or smoking. So the laboratory diagnosis that was done in our patient as well, it is purely dependent upon the clinical diagnosis, that is the characteristic generalized vesicular rashes sparing palms and soles. The diagnosis can also be made by the measurement of the varicella zoster virus specific antibodies in the serum sample, but in our patient it was negative. But it is not a sensitive test because it is usually positive only at 2 to 3 weeks following the infection. A Zang smear is another test that can be done, that is by taking scrapings from the lesion, and the demonstration of multi-nucleated giant cells are the diagnostic feature, is the diagnostic feature for the varicella, for the herpetic infection, which could be a herpes simplex or a herpes zoster. The most useful approach is a PCR, which is taken from the skin vesicles. The management in the patient, most varicella patients in healthy individuals is a mild self-limiting, it's mild self-limiting and uncomplicated. Antiviral therapy is usually preferred in patients who have got severe varicella, older age group people, compromised immunity and chronic diseases of the skin and the lung. The term severe varicella refers to the extensive and prolonged viral replication. A patient who has got fever, new skin vesicles for more than 5 days with or without the involvement of the lungs, liver and or brain. The treatment includes high dose IV acyclovir with supportive intensive care. Now, why was this patient toxic? Toxic shock syndrome is a toxin that is mediated, it's a toxin mediated acute life-threatening illness. It is usually precipitated by the infection either by the Staphylococcus aureus or group A streptococcus, that is GAS, also called as a Streptococcus pyogenes. The streptococcal toxic shock syndrome is also called as a toxic shock-like syndrome, which I've already mentioned earlier, that is, it is one of the main complications seen in varicella infection. So the main etiologies is the staphylococcal toxic shock and the streptococcal TSS. Staphylococcal menstrual related, that is use of tampons, is considered to be the main cause of staph TSS. The other non-menstrual causes includes, it could be post-surgical, postpartum, post-abortion, IUD placement, burns and soft tissue infection. Streptococcal TSS, the most common cause is after the viral infections including the varicella and influenza, pharyngitis, penetrating injuries and necrotizing fasciitis. So this is the pathogenesis in which superantigens are mainly responsible for the production of toxic shock syndrome. That is, it directly stimulates the T cells instead of the normal pathway of the antigen-mediated immune response, and it causes a massive cytokine release, which releases the interferon gamma, interleukin 2, and also TNF beta. And this causes activation of more and more B cells and T cells, and this is responsible for the inflammation, tissue injury, and shock. So superantigens contribute to the main pathogenesis of the toxic shock syndrome. So symptoms in a toxic shock syndrome is mainly due to two factors, that is toxin secretion and the infection focus. Fever, hypertension and skin changes are the main clinical features. The first symptom that the patient presents with will be the prodromal symptoms: myalgia, generalized weakness, headache, sore throat and diarrhea. It rapidly shows a progression to a diffuse erythroderma. Patient can have neurological manifestations which includes altered sensorium, confusion, and can also lead to coma. The cardiopulmonary manifestations include pleural effusion, pulmonary edema, the patient can have increased vascular resistance that can finally lead to decreased vascular resistance and increased vascular permeability, leading to hypotension. Presence of skin rash. Firstly, it appears as an erythroderma, later on involving the skin, and later on it involves a mucous membrane and finally leads to ulceration. So fever, hypotension and skin changes, these are the main clinical features seen in TSS. Diagnosis as done in a patient, we had all the full blood count, LFT, coagulation test, renal function test, creatinine kinase, electrolytes and blood cultures. We have a CDC criteria for the toxic shock syndrome that includes the clinical and the laboratory criteria. The clinical criteria includes fever, the temperature should be more than or equal to 38.9 degrees Celsius or 102 degree Fahrenheit. Rash should be appearing as a diffuse macular erythroderma. Desquamation which occurs 1 to 2 weeks after the onset of rash. Hypotension, that is a systolic BP of less than or equal to 90 millimeters of mercury. Multi-system involvement, 3 or more organ systems, which includes the gastrointestinal system, the muscular system, that is severe myalgia and a creatine phosphokinase of more than or equal to 2 times the normal. Mucous membrane, involvement of the vaginal or oropharyngeal or the conjunctival hyperemia. Renal involvement in which the serum creatinine will be more than or equal to 2 times the upper limit of normal. The hematological manifestation in which the platelet count is less than 1 lakh cells per microliter. CNS, the central nervous system, that is the disorientation or alteration in consciousness without focal neurological signs, where fever and hypotension are absent. So these are the clinical criteria. The laboratory criteria includes the culture may be positive for Staphylococcus or Streptococcus. That is, in a Staphylococcus aureus, only 6% cases may show positivity for cultures, and in a Streptococcus, only 60% may be positive for the streptococcal infection. So the cultures may be negative, yet it could be coming under toxic shock syndrome. Serological test, if at all obtained, it should be negative for Rocky Mountain spotted fever, leptospirosis or measles. So we can classify the case as a probable case and a confirmed case. Probable case meets the lab criteria and 4 of the 5 clinical criteria. And a confirmed case is when you meet the lab criteria and all of the 5 clinical criteria, including desquamation, unless and until the patient dies before the desquamation occurs. So management, it is IV fluids and resuscitation, and the treatment of choice is the IV antibiotics, which is usually the penicillinase resistant penicillins, which includes the cephalosporins. It can include the piperacillin, tazobactam, meropenem. Clindamycin is another IV antibiotic that can also be given to the patient. IV immunoglobulins, which inhibits the T cell activation, which is the main pathogenetic factor for toxic shock syndrome. It's still under trial, but it is also a management choice for a toxic shock syndrome. Take-home message for this particular presentation is that this was an eye-opening case on the potential of a very fulminant and fatal cause for a relatively benign self-limiting exanthematous illness. It was a rare case of varicella zoster where the blood cultures were negative for secondary infection, but the patient still had features of toxic shock syndrome. Blood cultures are positive only in 60% of the cases with streptococcal TSS and less than 5% cases with staphylococcal TSS. And last but not the least, prevention is always better than cure. So I would like to highlight the efficacy of vaccines in preventing the complications related to varicella, which is usually a two-dose course taken 4 to 8 weeks apart. Thank you.
So it is open for discussion, and I would like you to congratulate our trainee for meticulously going through all aspects of the Dr. Gilles, you are a teacher, so you should.
I have some comments. Actually, before the era of this acyclovir and vaccination for preventing this chickenpox, I have seen so many cases like this. Actually, at that time there was no treatment, no specific treatment. When I was working in the Taluk hospital some 30 years back, we were called for house visits because the patients, the relatives themselves will suspect such a condition. So we will go there. I was not afraid because I had already had a chickenpox. That was the vaccination. So I have seen these cases, similar cases. Most of them were fatal. We just give antibiotics, fluids and things like that, but they will not survive. No investigations were done because it could not be done. The patients could not be brought to the hospital. We used to call it hemorrhagic chickenpox at that time. Hemorrhagic chickenpox. That was a name. And in fact, there is a very sad case of one of my junior at Trivandrum Medical College, Dr. Padmanabhan. Some of you may know. He was working in the radiology department of Alpura Medical College as an assistant professor. And he had this hemorrhagic chickenpox. He succumbed. And a very tragic thing was, none of the staff or others, they were willing to take the body. They were afraid at that time. Because at that time, such cases were usually fatal. So she has gone into all the aspects of this case, and she has gone into so many things. I was suspected one more. I was initially thinking it was a Stephen Johnson syndrome. Another thing was, then considering all the investigation results, leptospirus was also it was in my mind. But I said 30 years back, the first diagnosis was hemorrhagic chickenpox. That is a clinical diagnosis, no specific treatment, antibiotics, paracetamol, etc. Some people survived, most of them succumbed.
Usually death in varicella is a pneumonitis, a myocarditis and things like that. But here we had a toxic shock syndrome. That the person was in typical shock. That was what was. Now come to think of it, she said that there are super antigens and they escape the ordinary immunity and they result in a cascade. That is what happened with COVID also. The super antigen escaping the normal immunity and creating a cytokine storm. So these viral infections are also capable of producing toxic shock syndromes. That is the message we want to convey. But the learning process for every doctor, trainee, seniors, is that we should go meticulously through the differential diagnosis, investigations, and then reach the diagnosis. That is what we have to tell them, and that is what we have to follow. Any more suggestions?
It was a clipping that was done, isn't it?
Yeah, because of that we also thought of a staph and strep test, and then these
so
infections.
I know it's very difficult to make a correlation,
the
but that was
smear.
one event that was again done in a non-medical setup. It was done.
Yeah.
So it's quite possible that that was a very.
That was one of our first thoughts.
Yeah,
That's why
yeah.
she mentioned it. But none of the cultures were positive, and the clinching point was the Zhang smear.
Yeah.
But Sanjana asked me a very important question. She said, we are going to say that the PCR is one of the tests. Why didn't we do the PCR? They are going to ask that. So I was at that phase a little fed up. I said, you say you don't know. But she gave me a very good answer. She said, ma'am, in the first few days we have to do it. But at that time we were not thinking of it. And then she said also, you are frightened that the infection could spread. But then again I thought, oh, that's a good thing. And I said, you say you don't know. But she had the answer for that. So that means the meticulous learning process has gone into that.
Sanjana, can you just tell me the sequence of development of the vesicles in the body?
Varicella zoster.
Yeah.
Yes. So first, its main targets includes the T lymphocytes.
No. I mean in the body. When you saw the patient, you were telling somewhere in the pelvic region or somewhere the vesicles first started, then it spread.
Rupturing, crusting was happening there, and hemorrhagic varicella lesions, vesicular lesions.
No.
Also
My point is, we have learned initially that the lesions of varicella zoster appear in crops.
Yes, sir.
Was there the sequence of appearance in crops in this particular case?
Yes, sir, because the thing is, he presented to the hospital 5 days following the initiation of the skin rashes. So most of them had crusted, and few of the vesicular skin lesions were also present.
Active lesions.
Active lesions were also present.
Okay.
Any role of hydrocortisone in this treatment?
We give them because they are in a toxic shock syndrome, a low dose hydrocortisone. I don't think it plays a big role, but we give people who are in shock.
No, it wasn't.
For this one, we know. But in shock syndrome, sometimes a low dose hydrocort is given.
Ma'am, any reason for the virulent cause in this patient? He was not immunocompromised.
That was another very interesting thing. This patient was not an immunocompromised person. So for us to believe that a varicella, a self-limiting disease, was causing this sort of a devastation in this, and his age group was 55 years. So that was the rarity of the cause. We did not think that it could be, like we thought of drug reactions, then we thought perhaps it's a secondary skin infection. Yeah, he was not vaccinated.
Any possibility of West Nile fever? For
Pardon?
discussion's sake. West Nile fever. West Nile fever.
No, we didn't think of this because, yeah, with the rash we could have thought, but when the Zang smears came, and Zang smears are typical, and we had the dermatologist, we had the help of the dermatologist, our critical care team, we cannot take credit for anything because critical care team looked after him very well. The dermatologist was in the picture. She and the pathologist told us that you have got the Zang smear, which is the definitive diagnosis for it. And then all our cultures were negative, but that can happen in any toxic shock syndrome, staph or strep. But we could not pick up any evidence. And then, of course, we reviewed literature. And then we came up with the understanding that varicella can cause a toxic shock-like syndrome. I suppose if it's a Western country, a post-mortem can be done, and then you get a correct, but we don't have the privilege of doing that. But the one thing which pointed to varicella is the Zang smear. Can we, if there are no more questions, can. So thank you once again, sir.